Hello, and a very good evening to all. I, Dr. Dhammadip Dabane, on behalf of MQ Pharmaceuticals Limited, welcome you all on the occasion of No Thrombosis. No Thrombosis is the live workshop wherein we discuss and understand about various thromboembolic situations in cardiology, and which will be based upon the real life challenging cases, like it may be the CAD-PAD, DVT, pulmonary embolism, atrial fibrillation, COVID-19 coagulopathy, etc. So based upon these cases, we will try to basically learn and discuss amongst the expert panelists today. So for that matter, before proceeding, I would like to just introduce to all the audience who are attending this program today that MQ been on the 9th edition of SIMS Healthcare Excellence Award for this particular scientific program. And we are really proud of that. So before proceeding now, it's my privilege and honor to welcome and introduce our today's course director for this program, Dr. Prafulla Kerkar, sir. Sir is the senior consultant and interventional cardiologist at Asian Heart Institute, Mumbai. Sir, being the former president of CSI Mumbai chapter, sir being the chairman of Board of Studies at MUHS, chairman of the Pinnacle India Registry in collaboration with SCC, been presented with various at various national international meetings, including the prestigious orations and the awards, been published with various papers at various national and international journals, and been part of various landmark trials like the Paradigm HF, Paradise MI, Odyssey Outcomes, Select, and etc. So thank you, sir, for joining with us for this particular virtual event today. Now, I would like to welcome our first course moderator for this program, Dr. Srijan Shaha. Sir is the senior vascular surgeon affiliated with the Endovasc Hospital at Ahmedabad, and been also the director of Dr. Bain's Clinic and also the visiting consultant at various prestigious hospitals across Ahmedabad. His area of interest is majorly into the endovascular interventions, the thoracoabdominal aortic aneurysms, and etc. Been part of various national and international conferences, and been also published various papers at various national and international journals. Thank you, Dr. Srijan Shaha, sir, for joining with us today. I would like to welcome our second course moderator for this program today, Dr. Hitesh Shaha, sir. Sir is the interventional cardiologist and the professor of cardiology at SAL Sterling, Rajasthan Hospital and Shalby Hospitals, Ahmedabad. Had 16 plus years of experience in the field of cardiology and conducted numerous clinical trials which are in his credit. Thank you, sir, for joining us for this meeting.
Yeah, good evening. Thank you.
Yeah. Now, I would like to welcome our first speaker for this meeting, Dr. Sunil Jatania, who is the consultant interventional cardiologist affiliated with the Anjana Heart Clinic and Diagnostic Center and various hospitals across Mumbai. Been published with several articles at the various national and international journals. I would like to welcome our second speaker for this particular meeting, Dr. Utsav Unadkat, who is the consultant interventional cardiologist from Krish Heart Care, Star Hospital, Ahmedabad. His expertise in the central venous line insertion, arterial line insertion, etc., been participated at various scientific meetings as a faculty. So with that short introduction, I would like to just go through this agenda of today's event. We will be having the opening remarks from our course director and the moderators, and we will go through the case presentations one by one. And each case presentation will be followed by the extensive discussion. So with that note, I would like to hand it over to Prafulla Kerkar, sir, for his opening remarks. Thank you.
Well, good evening to all. Well, thank you, Dr. Dabade, for the kind introductions that you have done. And you've already given a brief overview of what are we looking at tonight. We have, of course, my co-faculty today, are from Ahmedabad, but then amongst the speakers like me from Mumbai, we have Dr. Jatania and sorry, come again. It was Dr. The other gentleman is Dr.
Unadkat.
Oh, sorry. Yeah, of course. How can I forget Sorry, Dr. Unadkat. The namesake is very popular. Unadkat is the IPL big bowler who has joined us, Mumbai Indians. So basically, we have faculty from Ahmedabad and Mumbai. And as is very aptly titled, this topic is titled as no thrombosis. So no meaning on the one side, through this real world scenarios, moving away from the trials that we gain knowledge from, the evidence base from. Real world cases are challenging, and by virtue of these cases that are being presented in these no thrombosis webinars, we try to gain knowledge from each other. That is one thing, and how to handle real world cases. And the no in capital letters, I don't think that that utopian dream has been successful yet, about eliminating thrombosis altogether. That's the challenge. And as cardiologists, we're always playing the balancing act between thrombosis and bleeding on the other side. And we always get guided by the principle of plus first do no harm, and you'll end up under treating patients. So our intervention is, but here we are talking about intervening with solid molecules. And talking about solid molecules, we all understand that DOACs today virtually have replaced the good old rat poison, as we call it, the Warfarin, except for valvular heart disease, especially stenotic lesions, mitral stenosis, and the mechanical valve replacements. Leaving that, DOACs have replaced it, and two very established fields where DOACs have replaced it is in chronic atrial fibrillation as well as VTE, that is venous thromboembolism. But now amongst all these DOACs, there are of course no head-to-head trials for us to decide which one is which. But one can definitely say that the versatility of Rivaroxaban, especially there is today an guideline approved indication for Rivaroxaban for secondary prevention of, mind you, chronic coronary artery disease. So let us also, because we have very exciting cases today. One is the first one from Mumbai, from Dr. Jutania, who is, as you have heard, of interventional cardiologist trained at our own Bandra at the Holy Family Hospital. And he would present atrial fibrillation. So without much ado, before we go to Dr. Dr. Unadkat, before that, let us have, without much ado, Dr. Sunil Jatania. Go ahead, let's see what challenges you throw at the faculty. And of course, I would encourage all audience to send in questions so that, we can, and please be interactive in that sense. I know you can't come live and give, but in the chat box, please keep on posing questions to us. We have very bright people around here today. Yeah, and welcome Dr. Hitesh. I cannot really see you, but Hitesh is a very senior cardiologist out of Gujarat, and let us look forward to something. Yeah, Chalo, go ahead, please. Dr. Sunil Jatania.
Thank you, sir, for allowing me to. Yeah. Now help me share the slide, please.
Yeah.
My screen is visible?
Yeah. Yes, doctor.
My screen is visible?
Yeah.
Yes, very well visible. Go ahead. You can go on a slideshow, please. Yeah.
Yes, sir. Yeah, respected Kelkar sir, and all my colleagues and friends who have joined us for this interactive session. My name is Dr. Sunil Jatania. I am an interventional cardiologist trained in Mumbai. I am practicing in Kurla Ghatkopar area. These are the hospitals where I am attached, and this is my clinic here at Kurla in Phoenix Paragon Plaza. Today I'll be putting forth a simple case here. Purposefully, I have not selected any complicated case because still I see many of us struggling at a simple case like patients having AF, we know are high risk of developing stroke. So I thought let's discuss some basic points and then we can take ahead in discussion. So here is a 60-year-old male who is a diabetic, who is hypertensive, presented with left hemiparesis. MRI showed an infarct. Cardiac evaluation showed there is AF with controlled ventricular rate. Echo showed there was a LVH and a normal LV function. Patient was euthyroid. Based on CHA2DS2-VASc score, we know patient needs oral anticoagulant. Patient was started on low molecular weight heparin and warfarin. Patient was INR was titrated to 2.5. Then stopped low molecular weight heparin, and when patient was fine, he was discharged and was suggested to keep INR regular monitoring and to keep INR between 2 to 3. Patient's relative was a doctor, so he said he'll keep the track of all this, and we were happy with that. Unfortunately, then patient came again after few months, and this time he presented with TIA, brachial palsy, and again a small infarct was seen. The MRA, so the vessels were normal. ECG, as was expected, showed AF with fast ventricular rate, but the INR was 1.5. Now, we asked the patient, he says he was adherent to drugs. We were not sure whether compliance or not. We up-titrated the dose of warfarin. We advised to continue the drug without fail. We asked him to maintain a book with regular INR monitoring. And again, his family friend, the relative, he was there to take care of it. But again, the same scenario. And here he presented again with TIA. This time INR was 1.4. And I checked all the records and TTR was less than 50%. So, and we were not sure whether he was compliant with the drug or not, but he says, yes, he was taking it regularly. His LFTs and RFTs were normal. So we decided let's switch over to Rivaroxaban, and we switched over to Rivaroxaban 20 milligram OD. It's been 6 months now since the last TI event, and there is no further thromboembolic episodes. So here, what I did was I switched over from warfarin, where I was having doubt whether patient is compliant or not, but he says he is regular on medicines. But that INR titration, maybe some food or other things, but his INR was never in the therapeutic range. So we shifted over to Rivaroxaban. Let's discuss some trials related to it. Rivaroxaban Rocket AF trial, for example, where Rivaroxaban 20 milligram OD was compared head-on with the warfarin, the time-tested molecule, and warfarin INR was targeted between 2 to 3, and monthly monitoring and all that were done. Primary endpoint was stroke and embolic phenomenon, and they found that Rivaroxaban was non-inferior to warfarin to prevent stroke or systemic embolism. Also, what they noticed was that there was no significant difference in the major bleeding, but intracranial bleed and the fatal bleed were less with Rivaroxaban. When the meta-analysis was done, Rivaroxaban with the VKA, they found there was significant lower risk of ischemic stroke, and there was a significant lower all-cause mortality. Dabigatran and Rivaroxaban comparison meta-analysis didn't show much difference. Both were similar. So basically it was a basic case, but I thought, there is a lot of confusion still what to do and how to do. I thought I'll randomly go from slide to slide and try to guide how to use in what scenario. So first of all, if you see a patient of AF, it's not that you start just rate control and anticoagulate and all that. Try to see if there is any cause for AF. If there are some reversible causes, try to manage that first. As we know, long-term outcome, whether it's rate control or rhythm control, hardly any difference. Also, first when we were classifying AF, we would say paroxysmal AF, persistent AF, permanent AF. It's of not much significance because the stroke risk is almost similar. As we know, we do CHADS-VAS score and HES-BLED score and then decide about the need for anticoagulation and the risk related to anticoagulation. Now regarding NOAC, this is a very busy slide, but here I need some time for discussion, and let's pay attention on this slide. That dabigatran, for example, based on RELY trial, 100 milligram BD was non-inferior. So it is at par with the VKA, but 150 BD was proven to be superior. When redual PCI trial, that is when stent was also needed, 110 BD was suggested. Rivaroxaban, based on the Rocket AF trial that we suggested, the dose is 20 milligram OD and that is non-inferior to VKA. But if the creatinine clearance is less than 50, the dose should be 15 milligram OD. And if it is creatinine clearance is less than 15, Rivaroxaban is better avoided. In Pioneer AF study, basically this I will discuss ahead. Pulmonary embolism dose of Rivaroxaban we know, that is 15 milligram BD for 21 days followed by 20 milligram OD. And after 6 months, if the need is there, we can go down to 10 milligram. In case of venous thromboembolism in acute medical illness, to avoid that, you can use a 10 milligram OD for approximately 1 month. And we know for chronic coronary syndrome, aspirin plus Rivaroxaban 2.5 BD can be used. Apixaban, based on Aristotle trial, 5 milligram BD was proven to be superior. This 5 milligram BD, you have to come down to 2.5 milligram BD when age is more than 80, weight is less than 60, and creatinine is more than 1.5. If 2 out of 3 of this is present, you should come down to 2.5 BD. Endoxan we hardly have used, or we don't use it. There are reversal agents that are available, especially for dabigatran, and can be used. Now, some scenarios, like in my scenario, I needed switching over from Warfarin to Rivaroxaban. How to do it? If you want to switch from Warfarin to Rivaroxaban, you stop Warfarin and you start Rivaroxaban when INR is less than 3. In case of unfractionated heparin, you stop the infusion and you start Rivaroxaban at the same time. And from other anticoagulants, okay, you start Rivaroxaban say 0 to 2 hours prior to the next scheduled dose. Now switching over from Rivaroxaban back to Warfarin, it can be because of monetary issues or whatever. Now in that scenario, you can do a INR measurement of VKA before the next Rivaroxaban dose, and Rivaroxaban can be discontinued once INR is more than 2. What we mean is, patient can be started on Warfarin, and when INR goes above 2, you stop Rivaroxaban. Okay, so this is how we can do. This one busy slide again, though looks complicated, I would like to discuss here. Like some patients on AF, if they are needing stenting for coronary artery disease, then how to approach? So I just wrote this slide on paper on my prescription just to put it on the slide. So suppose patient is having this PCI done for ACS or not, we have to see that. So if the patient of AF, if has developed ACS or no ACS, this is ACS and this is no ACS, no acute coronary, if the patient of AF is needing stenting and it's not because of the acute coronary syndrome, then the triple therapy is only for 1 month. But if there is an acute coronary syndrome and hence stenting was done, then triple therapy has to be continued for 1 to 6 months based on the bleeding risk. I mean, if the bleeding risk is high or bleeding risk is low. If the bleeding risk is high, then continue triple therapy. Triple therapy, I mean aspirin, clopidogrel, and a anticoagulant. So that triple therapy to be continued only for 1 month. But if the bleeding risk is less, continue triple therapy for 6 months. After that, you have to go to dual therapy. That is a oral anticoagulant and one antiplatelet. And if the ACS is not there, that is stenting was not done for any acute coronary syndrome, then triple therapy is only for 1 month. Then you decide about dual therapy duration based on the bleeding risk. If the bleeding risk is high, continue dual therapy for 6 months. But if the bleeding risk is low, continue dual therapy for 12 months. And after 12 months, there is no need for antiplatelet. Patient is continued as monotherapy of oral anticoagulant only. Clear? Now, a few trials I thought we'll discuss, but I'll skip. Here in this slide, it looks a busy slide, but here we need to understand if patient has got dyspepsia or upper GI symptoms, then the drug choice should be Rivaroxaban, Apixaban. And because lot of dyspepsia is seen in at least 10% of the patient, as high as 10% of the patient with dabigatran. But if there is recent GI bleed, then Apixaban is preferred because there is more GI bleed with all these than with Warfarin. This we know. I think this is all that I wanted to discuss. I wanted to tell you all when to switch and how to switch between the oral anticoagulants. I wanted to tell you all how NOACs are used and what dosage, and I want to tell you all especially about a patient requiring PCI who is already on anticoagulant, then how to use what dual, triple, and then monotherapy. Thank you, friends. I think I have finished within time.
Yeah, great. That was a great talk, Dr. Jatania, with just making the case as a, what you call, it was a recurrent TIA kind of a thing, and that the limitations of Warfarin were very well brought out. And it's such a difficult thing. Even in the trial scenario, they have the TTR, something that is called as a time spent in a therapeutic range. In a trial scenario, you have as high as 70%, I guess, in the RELY trial. But that kind of a scenario doesn't happen in real world. Even despite their best efforts, patients are not able to maintain their TTR well enough. And therefore, there is no doubt, especially following a stroke, it's a class 1 recommendation today that you have to go in for a DOAC over Warfarin. So the use of Warfarin definitely goes out. Now the challenges about the cost and all that become secondary really, because the cost of a recurrent stroke is higher, right? Cost effective analysis wise. And thankfully, thanks to MQR like pharmaceutical companies, which have brought us now all these molecules, now that they are off patent at much cheaper rates. So one message clearly comes out of your presentation that you need to switch to a DOAC, and you pointed out that you shifted to Rivaroxaban. Now, one question here, and maybe my moderators, Dr. Srijan Shaha and Dr. Hitesh Shah, might want to come in here. One question that I would like to point out to you, and of course the moderators will also take part in it, and of course our other faculty, Dr. Unadkat, can take part in it, is that how early after a stroke, and how do you go about, say your patient was naive to stroke, you understood, naive to, I mean DOACs, and you understood that, yes, this guy has got a stroke and then he is in AFib. So putting two and two together, we need not really echo-wise, he may or may not have the clot, it might have disappeared. And it is a cardioembolic stroke just going by the history. So how soon can you start a NOAC? That's the question that comes up very often. And how do you go about starting the NOAC? Let's forget about the fact that this patient, you got him onto Warfarin. So how early after a stroke can you get a patient onto an anticoagulant? All kinds of strokes. Your patient is one aspect, but strokes, how early can you get started? That's one question that I would ask of you. Go ahead, Dr. Chaitanya.
Yeah.
Or maybe...
What we do is, we start on injectable, that is low molecular weight heparin for a patient who is having stroke. And before we discharge, we switch over to the oral anticoagulant. Like in this scenario, we had switched over because patient had AF and there was a reason for that, the embolic episode. So we switched over to Warfarin first. And then because of the monetary issues, as sir, you were discussing. But yes, I agree, sir, with you that if you actually consider Rivaroxaban as expensive, then try a stroke, how expensive it can be. With the life of the patient, with the income, with the family.
That's a very valid thing that you talk about. You said you would wait for a week and then get into it. Now, does stroke imaging, why don't we get Dr. Hitesh Shah into this? Dr. Shah, what do you think? Professor Shah, that how does infarct imaging change your prescription? Does it, or the stroke evaluation changes? Because there's something called as a... Go ahead, Dr. Hitesh, I would bring you in here.
Yes, good evening, everybody. In fact, our neuro team and we always discuss like how early to start the anticoagulation after the stroke, and the stroke imaging like functional protocols and area of infarct, they carry into importance like when there is a large area of infarct or in a infarct in a condensed area where in like basal ganglia or near into the brainstem, then propensity to start early anticoagulation is little less, because otherwise before the time of discharge, last 48 hours they overlap with the NOACs or whatever sort of anticoagulation strategy is decided if it is a smaller infarct. Otherwise, our neuro and team is still more comfortable with the antiplatelets to start on the very first day and put on the anticoagulation in last 48 hours of heparinization. So that is what protocol at our institute. And stroke imaging, it's like for magnitude of infarct, area of infarct, and it's like more of neuro perspective, but they calibrate the larger area of infarct, they have a risk of hemorrhagic transformation.
That's the worry, right? You want to, on the imaging, rule out and hemorrhage itself, right? That is the important aspect here. And also, I would like to bring in here that there's something known as a Diener's law, is what they call, right? So if you have just a TIA and not much really, they assess our neurologists tend to assess the stroke severity on the Rankin scale, or what they have all kinds of scale, mild, moderate, or severe. And by the rule of the thumb, it is generally between 1 to 2 weeks that you want to get started on a NOAC for these patients. But mild strokes, or for that matter, just TIAs, and for TIAs as early as 48 hours, within 48 hours, you want to get the patient onto an anticoagulation. If it's a mild stroke, you might go on up till a week or so. If it's a severe stroke, of course, you cannot before 2 weeks get onto it. That is what. So that is how they generally judge it. But generally between 1 to 2 weeks is a good time to start the anticoagulation. That's what it is, right? Yeah. So that is one thing. Then coming to, I don't think I can bring in Dr. Srijan Shaha, who's a vascular surgeon, but this PCI concept that you brought in, maybe we could bring in Dr. Unadkat also here, in what you gave a kind of a chart, and the latest ESC guidelines also do talk about it, isn't it? The ACS management guidelines also. Within that, stenting or an ACS means taking the bleeding risk into account. So what do you do, Dr. Unadkat? Do you really, it is a mental risk scoring, or is it like you go by the Hasbled, or you go by the arc bleeding score, What do you go by? And then you decide high bleeding risk person, you want to keep with your intervention, whatever the complexity of the intervention is, you want to keep the triple antithrombotic therapy to as low as possible. You might want to keep it as low as 1 week, is what he pointed out in a CCS scenario, like it's an elective angioplasty stenting. But what about in an ACS also, where is an extremely high risk scenario, whether 1 week might be good enough, especially I'm sure the young man that you are, you must be taking recourse to imaging. If you've done a perfect job, then can't we just knock it off earlier, meaning within a week or so? So I've asked you multiple questions. Can you get the
Yes, coming to the first question, sir, that in case of an ACS, what do you do? I'll see about a few risk factors the patient is having, how much of a multivessel CAD the patient is having, how diffuse the blocks are, whether they are eccentric blocks, discrete blocks, whether they are diffuse in nature, whether there is a lot of thrombus that is involved in the ACS, or it is just 90% stenosis that is causing the slow flow and everything like that. So that is one thing that I will keep in mind. Second thing is a patient who is diabetic is prone to have these kind of scenarios. So diabetes does play a role in consideration of this. What we generally do is dual antiplatelet therapy is a mandatory thing for the first 1 month at least. Triple therapy, yes, if the thrombus burden is high, I would consider it. And if it is a diffuse long disease, long lesion with a multivessel CAD, we will consider triple therapy.
Yeah, so triple therapy, but then with a NOAC, are you comfortable adding as a dual antithrombotic therapy, the more potent P2Y12 inhibitors, or you just want to, once a DOAC on board, then is it always clopidogrel? Dr.
I think as of now, we at the back of our mind, we do have that question mark regarding bleeding risk, though it is proven that it is not that much high with only a vascular dose of Rivaroxaban. But still, we prefer to start with clopidogrel if I'm going to start with Rivaroxaban.
Yeah, so
I have not
still safe about clopidogrel. Having said that, there was this one trial which really did not make big headlines as such, meaning the Compass made big headlines, and we are talking about chronic coronary syndromes actually. But the Gemini Cs Trial, wherein it was just a safety trial. I don't think the patient numbers were great. I think about 3,000 odd patients, and what they did is that they compared actually aspirin versus Rivaroxaban in ACS scenario, and the P2Y12 inhibitor was of the choice of the doctor, so to say. Of course, with ticagrelor, there was more, but the safety of using this dual antiplatelet therapy was shown in that trial. Dual antithrombotic therapy and dropping aspirin. And that aspirin is the villain that what this one proved, the West trial. So that has been there in that. So Rivaroxaban can be combined I'm talking about the 2.5 BID dose in a sinus rhythm. I'm not talking about atrial fibrillation scenario. But in a sinus rhythm, we have some data with that 2.5 BID.
2.5 vascular dose of Rivaroxaban.
Vascular dose is fine. But when it comes to AFib indication, the SPAF dose of all the three DOACs, we are not going to venture into giving
it's a relatively
or a P2Y12 inhibitor.
It's relatively untraveled territory, sir.
Sorry?
It's a relatively untraveled territory.
Absolutely. With that large dose, it is untraveled territory, but with a vascular dose, yes. So having said about the vascular dose, I think we are running over time for the first case. Let us get on to the second case. Since the second case is specifically involving coronary artery disease, let's keep a discussion to that. An excellent presentation, Dr. Jatania. Lot to learn from what you have presented, and we can, as time permits, discuss more. Well, let's go on to the next case by Dr. Unadkat. I'm sorry about trying to call you Jaidev, you are Utsav, but Jaidev is more popular, and now that he's come to Mumbai Indians, we find him really an asset.
I'm glad that my name is coming out in a good way.
Good.
I'll share my screen. Thank you very much.
Go ahead. Yeah.
Yeah. Is it visible?
Yes, very good.
Thank you. So, as Dr. Jatania had discussed regarding stroke patient, atrial fibrillation and stroke, I will be discussing a few things about something new regarding the coronary artery disease and peripheral artery disease patients. We had a patient over here who was a 61-year-old gentleman, came with a complaint of chest discomfort of class 2, and he had claudication since 1 year, was investigated, and he had a past history of diabetes and hypertension, multiple events of ischemia, had a PTCA and stenting to LAD at 12 years back. Then he had a CABG 10 years back due to stent restenosis, and then he had a stenting to RCA 3 years back again because the grafts had gotten closed, graft to RCA, and he had diffuse atheromatous disease of both the lower limbs. ECG showed sinus rhythm. Echo showed mild dysfunction with regional wall motion abnormalities of inferior wall, and the Doppler study showed diffuse disease of anterior tibial and posterior tibial vessels. Angiography was performed, and it showed a patent Lima to LAD graft and SVG to PDA graft, and LAD and RCA totally occluded with a mild CAD for the LCX. So in this case, we had a triple vessel disease with patent grafts, and he had an ACS, and he had peripheral artery disease which was diffuse in nature. So can we do something further to reduce his future events and improve the outcomes? That is what we always think about, right? So when we have a CAD patient, they do remain at high risk for recurrent ischemic events. The more risk factors they have, the more future ischemic events is what is found. So when we start any kind of a vascular protection therapy, we first have a baseline of lifestyle changes like healthy diet, physical activity, exercise, smoking cessation, weight control, and psychosocial support. Then we have basic 4 main pillars like lipid lowering with statins, ezetimibe, and PCSK9 inhibitors as and when needed, blood pressure control, blood glucose control, and antithrombotic protection with aspirin or DAPT. But is there a scope for further improvement? Let's see. Now there is a newer, these are the not newer but novel oral anticoagulants now. They have been here since more than 10 years now. And we have something called as factor 10A inhibitors and direct factor 2A inhibitors, that is direct thrombin inhibitor. Dabigatran is direct thrombin inhibitor. Factor 10A inhibitors are Rivaroxaban and Exafib. And so why do we add this? We know that histologically thrombin is the most potent stimulant of platelets, and aspirin and thienopyridines do not block activation of the platelet by thrombin. Blocking 10A inhibits thrombin formation from both intrinsic and extrinsic coagulation pathways, and platelet activation diminishes over time after an ACS event. But thrombin generation, in contrast, is persistently elevated following ACS and is related to adverse outcomes. This is reduced by Rivaroxaban. We have 2 positive feedback loops for platelet amplification. One is the ADP secreted by platelet. These activate the platelet, and again, it's a feedback loop. This is blocked by thienopyridines, and we have thrombin made on platelet surface, which further activates by the factor 10A. Further thrombin activation is propagated. So this is done by inhibited by Rivaroxaban. So in case of a stable CAD on aspirin monotherapy, there are different anti-thrombotic strategies that we can go forward with. If the patient is having history of multivessel CAD or an MI that is more than 1 year and less than 20 years ago, then if there is any additional risk factor like diabetes, symptomatic PAD, CKD, heart failure, or prior non-lacunar ischemic stroke, we have an indication for oral anticoagulation like aspirin plus Rivaroxaban. But if patient is admitted with an MI, treated with a DAPT, we have done an angiography. If a CABG is performed up to 12 months, you have to give DAPT, and then we can switch over to this vascular dose. If it is PCI, multivessel extensive CAD with diabetics, PAD, CKD, then we can give a DAPT, or if there is intolerance to ticagrelor, we can switch over to the vascular dose of Rivaroxaban. I'll come back to this once again once we discuss a bit further. So we have some new guidelines recommending Rivaroxaban. First is, let me discuss a few things about what is high ischemic risk and moderate ischemic risk. High ischemic risk is diffuse multivessel CAD with at least one of the following. This is a recurring theme that will be coming on. Diffuse multivessel CAD, vascular dose of Rivaroxaban is very important. So diffuse multivessel CAD with at least one of the following, like diabetes requiring medication, recurrent MI, PAD or CKD. In our case, we have diabetes and recurrent MI. Sorry. And what is moderate ischemic risk? At least one of the following, like multivessel or diffuse CAD, diabetes requiring medication, recurrent MI, PAD, heart failure or CKD with eGFR 15 to 59. Excuse me. So patient profile according to COMPASS inclusion criteria, and we have again, I have discussed a few things about this. In COMPASS trial, we had it. This was a randomized placebo-controlled double-blinded trial. More than 25,000 patients were enrolled with stable CAD or PAD. 3 arms were designed: Rivaroxaban 2.5 mg BD, aspirin 100 mg daily. Second arm was only Rivaroxaban 5 mg BD, and third arm was only aspirin 100 mg daily. And median follow-up was 23 months, that is nearly 2 years. So main trial outcomes were Rivaroxaban and aspirin both combined reduced MACE by 24%. Net benefit was 20%, and it reduced mortality of with to the tune of 18%. And there was no benefit with Rivaroxaban alone, and it was much better than compared to aspirin alone. When we compare regarding primary outcome in each and every way, there were significant little bit. It was pointing more towards Rivaroxaban benefit with a vascular dose. And when we compare to, we have these three main pillars like lipid lowering, BP lowering, and ACE inhibitors. When we compare, we have these three. We have significant benefit if we add the vascular dose of Rivaroxaban to these three pillars. Like MACE reduction over and above these three medicines was 26%. Stroke reduction was to the tune of 44%, and MI reduction was to the tune of 14%. Death showed a significant reduction with to the tune of 23%. So benefits of dual pathway inhibition are on top of standard control of lipids, blood pressure, and RAS blockade, and therefore should be used as part of the overall vascular protective strategy. When we compare, multiple landmark trials that were there that have happened till now, Capri showed clopidogrel, benefit of to the tune of 9% MACE reduction. Charisma of the trial having clopidogrel and aspirin as a combination, MACE reduction of 7%, but a little bit moderate, gusto-moderate bleeding elevation at the same time. Pegasus, that is ticagrelor and aspirin, MACE reduction of 15%, but TIMI measured bleeding was 160%. Pegasus, ticagrelor 60 plus aspirin, MACE reduction was to the tune of 16%, but TIMI measured bleeding again was 132%. While in COMPASS, we have MACE reduction to the tune of 24%, CV death reduction 22%, stroke 42%, MI 14%, which was non-significant obviously, but still it was there, and only 70% reduction, increase in bleeding risk. So COMPASS is the only antithrombotic regimen showing significant reduction in all-cause mortality. So clinical implications of this is switch from DAPD to dual pathway therapy. Therapeutic use and clinical benefits of DPI in both CAD and PD patients is now well established, and it is recommended as an option for preventing atherothrombotic events in adults with CAD or symptomatic PAD who are at high risk of ischemic events. So in this case, we added Rivaroxaban 2.5 mg daily over and above the other therapies that were going on. Thank you.
Well, thank you, Dr. Unadkat. That was an excellent presentation. And conceptually also, it sounds so correct, no? That you want to attack the platelet, you want to take care of the thrombin also. And as you very nicely showed in that graph, the thrombin activation that is persistent there. And an antithrombotic plus an antiplatelet agent is not something new, really. Good old days, I remember our professors, our bosses those days used to talk about give a little bit of aspirin, give a little bit of Warfarin, keep the iron a little bit on the lower side, and you will benefit them. Those days also they used to talk. Yeah. But the problem is that if you were to keep the INR in the therapeutic range, and there were many trials, in fact, a meta-analysis showed that the bleeding was 3 times. But yes, ischemic events were prevented, both strokes as well as MIs were prevented. And of course, the mortality was slightly on the plus side. So Warfarin went out, and then that taking that same thing and success from the Atlas trial itself, where again the intracranial hemorrhage was more, and therefore, and that was on top of dual antiplatelet. So one single antiplatelet, only aspirin and your Rivaroxaban in a very well conceptualized dose. I may just tell the audience also out here, it's not as if the other DOACs weren't attempted. They were attempted. They didn't go down that line. There was, what was that trial with Apixaban? There was an Appraise trial with Apixaban, which they used, meaning they did not use this, I believe. And they used the same SPAF dose, that is 5 milligram BID dose. IMG, and it was very high bleeding. They had to give up on that, and it was prematurely halted. Whereas dabigatran guys also, right from, it was just a safety trial, the REDEEM trial, and never came out with an outcome trial, but they started as low as 50 milligrams or 75 milligrams, 50, 75 and all. And they were able to show that as you increase this, the antithrombin activity increased and everything they were able to show, but they never pursued it. But hats off to Rivaroxaban people that they did it, and you got this a very remarkable trial that Compass was. And it is an indicated thing. Now, let us bring in our co-faculty out here, Srijan Shaha. It's a very hot topic with the vascular surgeon. So let's have some pearls from Dr. Srijan Shaha about how do you deal with this PAD business? How common is this? How often do you prescribe Rivaroxaban? And could you tell us as to the real advantage? Because you deal with all those legs and you amputate them, or you prevent amputation, or whatever it might be. So tell us about Compass in that context and your use of Rivaroxaban. Dr. Srijan Shaha, please.
Right, sir. Thank you. So in our practice, after this trial's result, use of DPI, that is 2.5 BID with aspirin or clopidogrel. Actually aspirin, but we have combined with clopidogrel also in selected patients when they had GI problems. The outcomes are quite good, not only in point of rest pain resolution or CLI resolution, but patients are compliant. They are taking the medicine, and if we have used for claudicants, even with for CLI, for post-stenting as well as post-op bypass, all 4 group of patients, we haven't found complications. The bleeding is something which we are looking at when we are combining these 2 things. So safety and effectiveness was already studied, and we also had the results. But bleeding also, whenever we have combined even with clopidogrel with 2.5 Rivaroxaban, there also we haven't seen bleeding. So it is very safe. And when I say DAPT, dual antiplatelet with 2.5 BID, that regimen I use particularly for those patients who have multivascular bed disease, coronary, renals, peripheral, carotids, and when they come with critical limb, I have gone for this regimen, aspirin, clopidogrel as well as 2.5 BID, and there also we have found good results. And after 2 months, we have switched down to classic DPI, that is 2.5 BD, along with aspirin and atorvastatin. So this has been really a great help for us. My daily usage would be in 7-8 patients at this regimen. So it's a quite a good number, and with all patients are also quite satisfied with the availability of lower cost molecules. They are very happy that they have got something, especially for diabetics. It works very good, and distal lesions, toe ulcers or toe tip gangrene, Definitely, we combine with smoking cessation, lifestyle modification, sugar control, but this works very good.
Yeah, so having said that, the message out here to the cardiologist is to look for peripheral arterial disease also. Atherosclerosis is ubiquitous. It's there across the vascular bed, and look for it. And especially in symptomatic people, there's no question that Rivaroxaban scores. And there was also that Voyager PAD trial as well, right? Compass PAD aspect plus the Voyager PAD. You got solid data there that peripheral arterial disease, this particular regimen of 2.5 BID. Having said that, you are even bolder. You guys, do you deal with very young patients? Now, we always get very worried when it's a triple antithrombotic therapy. And even in the Compass winning, there has always been a dual antithrombotic therapy, that is a DPI rather than triple antithrombotic therapy. Now, our PCI scenario also, of course, there we use a big dose of an anticoagulant, but we want to keep it as low as possible. But the message you give out here from the real world scenario is that even when the limb ischemia is really bad, you're okay to deal with triple antithrombotic therapy to begin with, going on up to 4 to 6 weeks as well, also, and then switching to dual DPI. Now, one very interesting point you made, and that conceptually seems like we all know from all other major data coming everywhere that aspirin is a villain, right, in the bleeding scenario. And to combine confidently without really the guidelines telling us that the antiplatelet, at least as far as aspirin is concerned, elsewhere in a chronic coronary artery disease scenario, one can switch. There was a recent post-AMI trial or something was there at some recent presentation where aspirin was switched to, where instead of aspirin, clopidogrel was given, and you actually had less bleeding plus improved outcomes as well. So having said that, what you tell us is that clopidogrel plus vascular dose of Rivaroxaban is a great strategy to go with.
Yes.
But of course, our guidelines don't allow us yet. Okay. Yeah. So Dr. Hitesh wants to add something. Go ahead, Srijan, you want to add something?
One point, sir. So 3-4 days back, I had a patient who was on 2.5 Rivaroxaban, aspirin and clopidogrel. He had 4 stents, 2 in iliacs and 2 in SFA, and had bilateral toe gangrene. So I had admitted for toe amputation. The day I admitted, he vomited a lot of blood in my hospital. The regimen was started by somebody else, but patient was doing quite good till that time. But I don't know, stress or the gangrene and infection was going on, and he vomited a lot of blood. Hemoglobin was 6. And then we stopped the aspirin and restarted with 2.5 BD with clopidogrel, and he is fine. As of now, he is fine. And it is definitely on paper, we have to be very careful when we prescribe this. But this clopidogrel and anti-DP, this 2.5 BID, the result-wise, I think it is better than aspirin. Recanalization or vascular recovery is better than aspirin. But because we are guided by trials, we use more aspirin rather than clopidogrel.
Okay. So that's a good point. Dr. Hitesh may want to add something about...
Yes, sir. In fact, most of the gastro people in our team, they are again against the aspirin. Whenever there is case of GI bleed, they always advocate us to continue with the clopidogrel and stop the aspirin on a priority. So, and with lieu of this Compass data in chronic patient and dual pathway inhibition, like one is antiplatelet and another is antithrombotic. So that Pegasus data where the 2 antiplatelets to be continued for long term for high risk patient, it looks safe and logical to continue with single antiplatelet and antithrombotic drug. With in a Compass data. Again, if you the way the previous trial, Capri, Karishma, etc., were projected, when the 2 antiplatelets were used, there were in fact Karishma showed negative results because there is more chance of intraplaque hemorrhage. What they proposed the theory. I think Dr. Deepak Bhatt was the principal investigator of Karishma, and when you use the 2 antiplatelets, there is 2 dual way of inhibition. There is increase in chance of intraplaque hemorrhage. And as far as the event rates in the peripheral arterial disease and the coronary artery, that has some different pathogenesis in terms of platelet activation and thrombus generation. So if we target one antiplatelet and second anticoagulation, Rivaroxaban or whatever drugs which is proved in trial, that looks more logical. And out of two antiplatelets, aspirin and clopidogrel, if this patient have a high bleeding risk or have a more tendency, then not guideline recommended, but preferred should be the clopidogrel plus NOAC.
So thank you, Dr. Hitesh. Meaning you have pointed out very well that this strategy makes sense on paper as well as in practice, real world data, real world experience. Dr. Hitesh has, Dr. Srijan has shared, and Dr. Unadkat gave us a very nice case to discuss all this, right? So, but very importantly, what Dr. Unadkat pointed out, he highlighted what is the moderate risk and what is a ischemic risk is what he highlighted. But in the same guidelines, what I would have loved him to do is to underline that without high bleeding risk for a chronic coronary artery disease patient, you want to get on to any kind of a dual antithrombotic strategy, may it be DAPT or DPI. It is without high bleeding risk. So high bleeding risk is something that is to be looked at. Unlike when we are using a HBR bleeding risk score and we are doing for a AFib scenario, what we gain ischemic benefit is way too higher than what we would in a chronic coronary syndrome scenario. Therein, if there is a high bleeding risk patient, and for me at least, if the history taking me, if my resident has not asked about a prior GI bleed or bleed anywhere, then he gets fired, is because you can't get onto a DPI or for that matter, even DAPT, we can't take it lightly, especially in the elderly. So high bleeding risk patient is a contraindication for a DPI strategy in a chronic coronary artery disease scenario without high bleeding risk. So that checklist, high bleeding risk, should be ruled out. It's like Dr. Srijan Shaha just tells us that somebody came in with a GI bleed and had a 6 hemoglobin. We don't want to do that. But having said that, there is in the Western world, at least in the COMPASS trial itself, isn't it? If you get a GI bleed or somewhere there is data that if on an antithrombo and on a anticoagulant, if you get a GI bleed, it's invariably unmasks malignancy within the GIT, isn't it? Malignancy elsewhere, also hematuria, you unmask malignancies with this kind of dual pathway inhibition strategies as well. So that is the other thing that we need to keep in mind. So anything else what is it now after this? I want to ask again, Dr. Unadkat, this strategy. Now you've got tons of patients who are following up. Is all fine. Good old days, we used to omit your second antiplatelet after a year, uncomplicated PCI, you've done it, so he's not going to get that early stent thrombosis, so he hasn't got it. Now 1 year later, he's come to you. Now, how do you base your further? Now, this is all about prevention, isn't it? We are not, if he bleeds somewhere, then doctor has caused it. If you have prevented it, nobody is going to give you credit that he's going to live long also. That's what you say. So how do you base your decision about the DPI strategy? Which are do you selectively pick out some patients? After all, it is 1.5 times the bleeding, right? 1.7 times, even in the COMPASS trial. So how do you pick and choose? That is one message that I would like you to give to the audience out here.
Yes, very rightly, as you said, sir.
Somebody who is on in your practice only on a single antiplatelet has had a MI some years ago, 5 years ago, has had an MI. And now suddenly, because we are all discussing this, what would you do? Go ahead.
Yes, in case of, this kind of a dilemma, I had in my uncle himself. He had 2 MIs. One was 10 years back. And then again, within 1.5 years, he had a second MI. So in his case, I was not a cardiologist at that time. And I was just entering, the final year of my MBBS and everything at that time. So that kind of a question was there, that how can I do something to help him in his, future outcomes. So in his case, he is a diabetic. He is having a stable course as of now, no new events. He doesn't have any kind of an exertional angina, no symptoms at all. He walks around 7-8 kilometers every day. So in his case, I went through the data and everything. Diabetes is itself one of the risk factors, major risk factors. and he had 2 MIs previously. So I thought that only aspirin will not suffice in his case. And again, he in his case, he had a bout of claudication previously, but after taking DAPT for some time, it got relieved. So in his case, I decided to switch over to a DPI, and then as of now, he is not having any symptoms regarding claudication at all. So that was one case. In case of regular patients, if the patient is not having a high bleeding risk, if a patient is a diabetic patient and there was a history of an MI before, say about 2 years back or something like that, that is more than 1 year, then I would definitely give a DPI to him. But in case of we have a DAPT score that we calculate after 1 year. If the DAPT score is 2 or more, then I will like to continue dual antiplatelet therapy for the course of 3 years and then switch over to something like a DPI.
Okay. So you would,
because the stent sizing and everything also comes into play. That less than 2.5 mm stent if it was used, and if it was an ACS at that time, these all things criteria like DAPT score, it does help.
It's a very well taken point that you would want to. You still have a comfort zone of yours. Using a DAPT has been there for so long. Being a stentographer, meaning a person who stents routinely. For you would want to do that. I'm just asking you that you gave us 2 what we call the compass enrichment criteria. You said your uncle was a diabetic and he has evidence of peripheral arterial disease. So polyvascular disease is extremely important for DPI strategy that you take into. You also told us about the REACH criteria, like that they have done CART analysis and look at the entire REACH trial registry. From that they took the factors, and when they decided on those the risk factors, the other things that they include is a renal dysfunction patient, somebody who's got mild CKD in addition, that is there. As also patients with 2 MIs. What you may have forgotten to say is that the LVEF being down, that is the other thing. So these 4 things people, and of course the highest risk people, the smokers also would come into that. So these are the people who would benefit. Now only grouse here is that the MI benefit was not great. I would bring in Dr. Hitesh again here, or maybe Jatania can come in and Dr. Jatania can say the MI benefit is not great, right? Prevention of an MI wise, it did not reach. Of course, we are doing too much hair splitting, and the primary endpoint wise, it was beneficial, but MI reduction is only about 14% or thereabouts, relative risk reduction. But the stroke benefit is the hugest. So having said that, the peripheral arterial disease patients, or if you have had a previous TIAs or anything, meaning the peripheral arterial disease, not just looking at the limbs as such, but if you have had a prior ischemic stroke or something, then to definitely it is a great strategy to use a DPI. But what, as cardiologists, some people have always raised the issue is that MI benefit was not as much as the stroke benefit. One must remember that they need not always get their eventual outcome, eventual event as being an MI. You might land up, this patient is at a very high risk of strokes itself, and stroke prevention was the highest. And surprisingly, they also found some mortality benefit as well. So definitely a proven strategy, and we would all love to embark upon it, is what it is. Hitesh or Sujal, my co-faculty, any parting words that you would want to give? Yeah. Jatania, you didn't come in. Do you want to add anything to what is being discussed? Or yeah. So Dr. Hitesh, anything more to add on that? Then we could.
Yeah. So in fact, prevention of stroke is not actually much clinically appreciated as far as the patients are concerned, because in most of the, as far as the patients in atrial fibrillation, because one bleeding risk or one myocardial infarction is going to be looked at as a clinical event, but prevention of stroke is not to be looked at clinical event by either by the patient or even by the consultant. So there is still like the indication wise, more and more number of patients like those who are really indicated for NOACs is still underutilized therapy because in our scenario, many of the patients are being treated at a physician's level, and they're still utilizing, there is significant underutilization of the NOACs in a genuinely proven indications.
Yes. So thank you so much, Dr. Hitesh. Dr. Chaitanya, you might want to add something, or you're fine with what we've discussed up until now. Dr. Srijan Shaha is also winning. He too gave us real pearls about peripheral arterial disease, and he too even goes ahead and tells us that as a DPI, you may want to add on with clopidogrel. Anything else that we are missing out here as clinicians that we should look for? Would you tell us something about ankle brachial index, and how does one really look for peripheral arterial disease?
Sir, ABI I used to check when in 2012 and 13, in early part of my career. After that, it is more of a limb feel and symptoms and Doppler report from outside. We have a hand Doppler, but we do it only for those patients where we are really worried about going ahead for doing something in once or twice operated elsewhere. Otherwise, immediate post-op or immediate post-stenting or post-plasty. But what you said about regimen part, we have already discussed. And as I mentioned, triple agents, aspirin, clopidogrel, and Rivaroxaban, I prescribe very carefully when I am really concerned about limb salvage, and particularly in distal vessel disease. It may not help in aorta and iliacs, but definitely when there is tibial disease. And as you ask, young patient, do I prescribe? Yes. In Burgess disease also, the thromboangiitis obliterans, where the vessels are very tiny and there is superadded thrombus, this works very fantastically. So these are the patients who come with some sort of gangrene or tissue loss. The results are awesome. So there you can combine all three. I will not add all three for stable patients or classic angioplasty or classic bypass cases. But whenever there is something extra needed, at least for 1 month, I'll add all three.
Okay, great. So we've had an excellent discussion today. We had some very good cases. We've had Dr. Chaitanya discussing recurrent strokes due to Warfarin, not necessarily non-compliance, but the unpredictable funny drug that Warfarin is. I would like to call it a funny drug, right? Yeah, so Warfarin is, and how a DOAC like Rivaroxaban, how it helps. As also we discussed with him about how to go about PCI in a patient of AFib and who's come with a ACS maybe, and how do we go about handling that. Then we've had Dr. Utsav Unatkat telling us about how to deal with the dual pathway inhibition for a chronic coronary artery disease patient, and his patient was a post-bypass patient, and how that he would go about prescribing, and he would confidently switch anybody who has got this compass enrichment criteria that we discussed. We discussed about at least 4 or 5 criteria about compass enrichment criteria. Most importantly, polyvascular disease. If you have got along the arterial bed, if you have, say, a carotid bruit also, and if you have had some TIA-like symptoms, then this patient definitely, in addition to, as cardiologists, we look at only the coronary tree. That is one. Polyvascular disease, diabetes, then not exactly, HFrEF also is a part of it, but LV dysfunction, EF being in the up to 30% was the EF included in the COMPASS trial. So low EF patients, as most importantly patients with associated CKD, if you have all these 4 or 5 and smoking, if you have all these 4 or 5 criteria, definitely one is confident enough, and though at the risk of bleeding, and of course after having ruled out high bleeding risk, then these patients become candidates for the dual pathway inhibition strategy. And Rivaroxaban in a dose of 2.5 BID, one would confidently switch over even a single antiplatelet patient to this, as also a dual antiplatelet patient coming to your clinic with a chronic coronary artery disease. You would switch and specifically look for it. That is what is the message today. And thank you so much, all co-faculty, and thank you so much, delegates. I think I should hand it over to Dr. Dabade for the final conclusion of the session. Thank you, Doctor. Thank you, MQR, for enriching us today.
Thank you very much, sir.
Yeah. So, sir, just the matter of vote of thanks very nicely covered two cases. One was at the one point who talked about the highest dose of the Rivaroxaban. One at the another point who talked about the lowest dose of the Rivaroxaban, the rational and the therapeutic usage of Rivaroxaban being talked about. So I think the whole audience who are watching us lively must have been enjoyed with all those wonderful discussions across. I'm really thankful, Dr. Prafulla Kerkar sir, for directing us throughout the course, and both the moderators today, Dr. Srijan Shaha and Dr. Hitesh Shaha, for nicely moderating in between the discussions. And last but not least, both the speakers brought up those cases, Dr. Sunil Jatania and Dr. Utsav Unadkat, in front of all of us. So before concluding now, I would like to request my team to play a video, which is a short 1 minute video, which is all about the development of Rivaroxaban at MQ facility. Over to my team. And with that, we will say good night. Yeah. Over to my team.
Good night.
Do you know which Indian pharma company has consistently launched innovative first in India products? Presenting MQ Pharmaceuticals. With over 500 scientists, we are pioneers in chirality. We have been making a healthy difference to countless families. With cardiology at our heart, we have strived to give you better products always. Chiral products are complex to develop. They are difficult to manufacture, but their benefits make a difference. A difference for your patients, for you. We are proud to launch our latest chiral development, Exafib, our indigenously developed Rivaroxaban. Developed in-house, manufactured at our state-of-the-art facility at Jammu. This is a WHO GMP certified facility. We conduct quality checks to ensure only the best is delivered. Exafib complements our chiral cardio portfolio. Exafib, committed to make a difference in anticoagulation therapy for your patients.
Okay. Thank you, sir. Very good night, and wish you a good time ahead. Thank you.
Yeah. Bye-bye. Bye-bye. Good night, everybody. Thank you all. Thank you.
Good night. Thank you.
Bye.